20 years now. I started in the area of the biology of type 2 diabetes, looking at some of the complex factors that underlie diabetes, and I was trained as a geriatrician, so I wanted to kind of merge the biologic skills that I had with aging. So I started working with Linda Fried about 20 years ago, and we developed the frailty phenotype, and sort of the rest has been history. So what I'm going to talk about today is the biology that we think underlies frailty, and the sort of the pathway by which we've gotten there. So as geriatricians, again, I'm a trained geriatrician. I still see patients, and unfortunately still take call every few weekends in the hospital. And so I think for geriatricians and for various subspecialties in medicine, our goal is the same for older people: to improve health and quality of life for older adults, to extend a healthy, cognitively and functional lifespan, so people without dementia and moving as best they can, and then treating various diseases and conditions that impact health and well-being. So that's a mission that most people have. Geriatricians tend to think about the first two as well as the third one a lot. So some of this comes from the thinking about frail people and how their outcomes are frequently much worse than more robust older adults. So this is a picture of my great aunt and great uncle. So the man on the left is my grandfather's brother, so he's still alive. He lives in Tucson, Arizona. He's 97, and his wife is 99. This was taken a couple years ago, and I use those as sort of the role models. We're trying to get people to live by themselves as healthily as possible, well into their late life. And I like to point out here that somehow they got there by not living the most healthy lifestyle. You see that she has a can of Coca-Cola there, and he has a horrible sweet cake that he eats all the time. And that's really pretty much what they live on, but somehow they've still made it to be this age. They're certainly getting frail now that they're in their late 90s, but they've tended to do very well functionally and cognitively. So I'm going to first conceptualize frailty, because I think frailty is sometimes a difficult concept because there's so many definitions, and I know in the next session and tomorrow we'll talk more about frailty and its increasing profile in aging research. I'll talk about biology and what we think underlies it. And then, importantly, what we've tried to do at Johns Hopkins is to translate the biology that we've discovered into clinical solutions, and I'll talk about a couple of those. So if you think about older adults, there's a big spectrum of people. So independent people like my great aunt and uncle, they have a few health problems, but they're generally pretty active and robust. And we don't see too many of those in the healthcare system, maybe in the outpatient clinic. More in geriatrics, we see people out here, many medical problems, in and out of the hospital, and becoming close to becoming dependent, needing to go into a nursing home or some kind of facility where they actually leave their house and aren't able to really take care of themselves. So trying to find people down in this area with frailty tools there are many tools that you can find people, and I'll talk a little bit about those. But again, we've been trying to focus on the biology that gets people down to this stage of life. So there are two major conceptual models for frailty at this point, and I know in the next session we'll hear about tools to measure people, but I think it's important before we dive into the biology to kind of think about the concept. So Ken Rockwood in Canada developed a frailty index many years ago, and that's an index of various comorbidities and disabilities. So basically, the more disabled somebody is, the more medical conditions they are, the more likely they are to be frail under this conceptual basis. And this is represented here by all these various things that can, everything from incontinence to bad teeth to heart failure to being in a nursing home, all contribute to this concept of frailty in that model. The model that we've worked on over the years is the frailty phenotype, and again, this is a model that's based on people getting weaker, muscle weakness, slowing down in their walking speed, feeling fatigue, low levels of physical function, and weight loss. And we hypothesize that there's a very specific biology in the middle, a changed biology that then drives these outcomes. So I'm going to walk through some clinical cases that I've seen. These are now several years old, but I think it helps to illustrate the conceptual framework that we use to identify the biologic changes. So the first case is a 75-year-old gentleman who came for knee replacement surgery. He had a history of hypertension and stable congestive heart failure. He walked a fair amount for exercise most days, but his knee was getting painful to the point that was becoming impaired. So he had his knee replacement surgery without any complications. He went home 2 days later, and he started on a pain and anticoagulation regimen, the standard regimen, and he received home physical therapy for about 2 weeks. So he was a good outcome patient. We see that's the outcome we want when we have people getting procedures. The second gentleman was also 75 years old. He had the same surgery. He was hypertensive and had stable congestive heart failure as well. He was a fit, vibrant hospital volunteer. He worked in the hospital with older people. And he did some exercise, but not quite as much as the other gentleman. He went to surgery and didn't initially have any problems, but then he got delirium on the narcotics that he got for pain. He felt getting out of bed in the hospital. He developed incontinence, and then he started refusing all of the PT, OT interventions, so saying, no, I don't want to take any of those interventions. So we then sent him to a skilled rehabilitation center. So instead of going home after 5 days, he went to another nursing facility where he got better over about 2 weeks and then went home 18 days later and got physical therapy for 2 weeks. And then, according to his wife, 3 months later, he was close to his baseline. So even though those two patients looked very similar when they came in for their procedures, one of them had a really good outcome. And the other one had a pretty bad outcome. He ended up being okay, but he didn't go through the procedure as well as one might expect. And so that's why we would hypothesize that he had some different biologic underpinning that made him less responsive to stress. And again, what we're trying to get at in our research is that biology. What is the biology that makes somebody, an older person, so much more vulnerable to having bad outcomes? The third case is somebody who I think everyone would recognize as being frail, an 82-year-old gentleman with a non-syncopal fall. He was just too weak to get up after he slipped to the floor. He had high blood pressure, osteoarthritis. He had had a hip fracture a couple of years before, and he had lost a fair amount of weight over 3 years. He walked around inside the house but didn't go outside very much. When he came to the hospital, he was weak, but no evidence of major depression. We thought he might be depressed because his wife had died a couple years before. And he came in for observation just to see if we could figure out why he was so weak. We didn't really find anything that specifically explained why he was weak and failing. He went to a skilled nursing facility, and he was walking about 30 feet within 2 weeks. So he was, again, walking and didn't appear to have anything different wrong with him. But because he was so weak, his family didn't want him to go back home. So he went to a nursing facility, and he died there about 3 months later of a cardiovascular etiology, we think. But it wasn't clear, probably a pulmonary embolus. So this third gentleman was very clearly frail by many criteria, and but I think also represents some biology that was driving him towards this eventual outcome. There's been a lot of work in the frailty world. Leo certainly has done a fair amount in helping to kind of gather the international community around this concept, helping people to better understand what it is and to begin to understand the biology that underlies it. A recent international consensus conference on frailty that John Morley and many others led basically was talking about this concept of physical frailty, again, an underlying construct that there's some changed biology that makes a subset of older people more vulnerable to bad outcomes. So some of the points that were made there is that there are screening tests that are already available for this, and we'll hear more about them later today and some tomorrow. Some recommendation came out that people over 70 with weight loss should be screened for frailty. And again, I think that was probably true for those individuals that I presented in the cases. They would have been picked up as being vulnerable. And then it's an emerging important medical syndrome, although it hasn't sort of entered into the mainstream of diagnostics yet around the world. There's certainly a lot of movement in the United States towards a diagnosis of frailty. And then what's important about that is that if we can figure out exactly what it is, if we know the biology a little better, we're going to be able to begin to target treatments and potentially intervene earlier before people get to that very vulnerable state. So the physical frailty, I'm going to mostly talk about physical frailty, not the sort of comorbidity type frailty that people also measure. So we call it an age-related syndrome of weakness and fatigue. It's highly associated with adverse health outcomes, including early mortality. It's a big warning sign of impending mortality. It's driven by complex age-related biologic changes in multiple systems, and I'll talk more about that. And it certainly, in our view, coexists with disability and with chronic illness, but can exist independently, and that's where we think this biology that we're beginning to get at is plays an important role here. So the original phenotype detection tool that we used was developed by Linda Fried and myself and several other people back in the early 2000s. And basically, we operationalized these 5 components, so weight loss, weakness as measured by grip strength, a feeling of exhaustion, slow walking speed, and low levels of activity. And these were chosen in part because of our clinical experience, seeing that this subset of patients that were doing poorly often had these characteristics. And so we used that as a starting place to begin to identify people who were frail by this definition. And we could also then identify people who were robust. And then from there, we could begin to study them individually and begin to understand the biology. So using this tool in the US, this is a prevalent study that was done in 2011. So this is some relatively recent data. About 15% of the US population over the age of 65 who lives in the outpatient setting, again, not in a nursing home, fall into this frail category. Pre-frail are people who are sort of in between that. They're weak maybe, or they're losing some weight, or they don't do very much physical activity. And then the robust or the very super fit people are about 40% of the US population at this point. And you see that changes with age. There are more robust people in the 65 to 69 age group, and by the time people get into their 80s and 90s, many more pre-frail and frail than robust, which you would expect. There's also, I didn't present this data, but there's some marked racial differences in the US as well, with African Americans and Latinos having more frailty, a higher percentage in the older population than Caucasians. So we looked at the outcomes of these frail people, and these are just a couple of very large population studies. This cardiovascular health study had about almost 6,000 people in it, and the Women's Health and Aging study had about 1,500 people in it. And basically, these are the outcomes that were associated with being frail. So imagine we looked at the frailty status at baseline, and then the patients were followed out for about, in this study, for 3 years, other studies for up to 10 years. And the major finding here is that the risk for mortality in this group is very high. So twice as likely to die in the cardiovascular health study if they were frail compared to the non-frail group, and 6 times more likely in the Women's Health and Aging study. And this has been played out over and over again. If you find somebody who's frail, their mortality rate is much higher. You see other things here like risk of disability, significant risk of becoming disabled, worsening mobility. Again, over 3 years, you just see a trajectory of people who are frail that is much worse. So these early studies, and again, these are two published ones, but there are probably 50 at this point in other studies and other cohorts that show that this particular frailty tool can identify people who do poorly. So we sort of know who they are, but we don't exactly know what underlies that vulnerability and how to impact it. So that's basically where we've turned our attention. This is, and we'll talk much more about this tomorrow, and I think later today we'll hear more about this as well. But some of the early studies we did back in 2010, looking at the risk assessment in other patients besides a regular geriatric patient, we know that if somebody's frail, they're 20 times more likely not to go directly home after surgery. So again, it's a way to say, okay, this is a frail patient. We know that they're not going to do as well, so we have to pay more attention to them, because for sure they're not going to be going home as often. They may end up in a nursing home or other places with many complications. And they're also very, very likely to have, much more likely to have bad complications after surgery. And these were all general surgery patients, hernias, colon cancer, mostly intra-abdominal procedures that patients were getting that showed this. So, and it also showed that the frailty screening tool was added significantly to the predictive power of all surgical risk assessment tools. So right now in the US, many tools are used to find people who are at high risk, but if you put frailty with that, it greatly improves the ability to find the people who are going to do poorly. So it's not necessarily tied to one particular tool. Our tool that we developed was used for this, but there are many other tools that can help you find people who are going to do poorly. Now, what are you going to do differently with those patients? That still remains to be seen. I think that's a very active area of investigation, and we'll talk more about that in the coming sessions. I'm going to get some water. Okay, so maybe I should drop my pens again so people will wake up. Is it time for that? Okay. So frailty. Next, I'll turn my attention to the sort of main part of the seminar, is the biology. So again, we think we know who frail people are. We can find them through various tools, but we don't really know what's different about them. What makes them more vulnerable? What makes them more at risk for having bad outcomes when they're stressed, put in stressful situations? So we know also it's increasingly clear that there's something different about frail people that sort of lays the groundwork for all the other things that we see in geriatrics. So frail people are much more likely to fall. They're much more likely to have delirium and incontinence. They're much more likely to progress in their chronic disease states. Their acceleration rate is faster. They're much more likely to have mild cognitive impairment and sarcopenia, so muscle mass loss. So all of these things are probably related to some very basic aging biologic changes, and that's, again, what we're trying to get at with our research. So this was a paper that was published back in 2013, which I think is a really great way to start thinking about how biologic aging impacts our patients. So there's a lot of molecular biology research right now, and as clinicians, it's often, you sort of hear about it, but it doesn't really make much difference on the day-to-day way that you take care of patients. But just, I think in these sorts of meetings, it's good to kind of look at these areas so that as this new information gets filtered into clinical practice, it's sort of a good place to have some knowledge. So all of these areas are very active areas of research in aging, biologic aging, so intracellular communication changes, genomic instability, telomere biology, epigenetic changes, loss of proteostasis, nutrient sensing, mitochondrial dysfunction, cell senescence, and stem cell exhaustion. And not that all of these things play a role in frailty, but probably there's some components of each of these things that are changed in frail people more than robust people. Most of the attention probably in frailty has been over here with stem cell changes, cell senescence, and mitochondrial dysfunction. And I'll talk a little bit mostly about mitochondrial dysfunction but there's certainly active areas here. They're probably less tied to the clinical outcomes at this point, but again, a lot of activity in these three domains. So just a piece of advice as you look at the medical literature in the next few years, these are probably the main areas where we'll see some emerging clinical practice changes from these biologic domains. At the National Institutes of Health in the US, there's been a big geroscience initiative. I think there's increasing realization that these molecular changes that I talked about really do drive a lot of the disease states that we see in older people. So there is a reason that older people get more chronic diseases. There's some underlying biology, and it's around some of those same areas that we talked about. So there's been an increased focus on more studies in these areas, but also in then connecting these changes to these disease states that we see in people, everything from cancer and dementia here to frailty, hearing loss, diabetes, COPD. So again, this is a very important area of focus in the US, and I think, again, we're beginning to see some of the early translational information come out of it. So back to frailty. We've worked again for many years on trying to figure out how you get to these outcomes. So we know that frail people have these bad outcomes. We know that they fall, they become disabled, they become dependent, and they die at faster rates than robust people. We know what they look like through those exams that I talked about: weakness, weight loss, slowed performance, exhaustion, and low levels of activity. And these two slides, domains, represent probably 100 studies that we've done over the years. I just put a couple in here, but the major physiologic associations that we found over the years include increased markers of inflammatory pathway activation. So we know that frail people have more IL-6, more white blood cells, more CRP than non-frail people, so there's this activation. They have more clotting factors in their blood, D-dimers and fibrinogen, so they're more likely to clot. They have glucose intolerance even if they're skinny. They have some metabolic abnormalities that don't allow them to process glucose as well. They have lower levels of IGF-1 and DHEAS, which are hormones that are important in muscle mass maintenance. And they have high levels of cortisol, higher levels of the stress hormone cortisol in response, especially in the afternoon time points. And again, this has been shown over and over again. So in summary, sort of activation of these stress response systems and energy metabolism abnormalities. Tying it out to the molecular biology has still been difficult. We know, we understand more and more about mitochondria and how those impact the inflammatory pathways, but and autophagy as well, but some of the other connections are still iffy. We think that they will be increasingly understood and how they might drive some of these things. Certainly we know that disease states play a very important role. So somebody who has congestive heart failure, for example, or a chronic bone infection will get some of these same physiologic changes. You'll see those in the bloodstream, and they'll go on to have these abnormalities as well and high risk of bad outcomes. But it's probably, a lot of it is mediated through these physiologic pathways. So again, for example, if somebody has a low-grade infection or rheumatoid arthritis or a low-grade cancer that hasn't been picked up yet, they often have these characteristic signs and symptoms. They have higher inflammatory factors and clotting factors. And these are the people then that would also go on to have more complications. They'd be more likely to have a heart attack or a stroke or some other adverse health outcome. So we know that this biology is important in connecting to these outcomes. It could be from aging biology, and sometimes it's from disease. So it's important to recognize that both of these things are happening. This is an even more complicated slide, and trying to put this together. We spend a lot of time thinking about these various hypothetic models so we can begin to test them. I think that's been our one of the ways we've been being able to unravel some of the changes, biologic changes. Again, those are those biology of aging changes here. We know there's some genes and some environmental changes, certainly diet, exercise, all of those things can improve these, or if you don't do them, make these things worse. And then disease states, as I mentioned, these are the major diseases that have been associated with frailty, probably mediated through this physiologic pathway. And these are some of the reasons that older people are more likely to have changes in these systems. So I wanted to bring your attention to the physiologic pathways here. So you see inflammation, angiotensin system action, HPA axis activation, sympathetic nervous system activity, and decreased energy production is sort of all major physiologic hallmarks of physical frailty. So we know that these things are changed, mostly through some animal studies, but mostly in human physiologic studies, studying frail to robust older adults. And one more way of thinking about this that I think has been useful for us over the years, maybe I'll try to point over there, so that side of the room. No, it's not going to work, sorry. Oh, there, okay. So out here we have what we see in the clinic, so I put clinically apparent there. And around there we know that frail people are weak and they have slow gait and they don't do very much physical activity. They have some other lab characteristics that I put in here, so mild cognitive impairment, increased clotting factors, anemia, low albumin, and cholesterol. So we often see that in the clinic, and we don't quite know what to make of it. We know those people aren't doing very well. We don't exactly know what's causing it. We just know that we see it. And often these things aren't treated. We don't really know what to do with mild anemia, or if you see an elevation in fibrinogen or something like that that gets picked up, or even mild cognitive impairment at this point. We really don't know what to do about it. So this is the line where we see what's happening above the line in the clinic. But down here are all these biologic changes that are happening in older people. And again, it's pretty complex and often daunting to think about how are we ever going to figure this out, because an older organism is beginning to change in ways that we can't obviously see. But I think over time we've begun to understand that things like immune system changes and activation of inflammatory pathways that are probably in response to something happening down here or to a disease state, certainly characteristic, and we know that it probably is driving some of these changes that we see. We know HPA axis is abnormal with higher levels of cortisol and frailty, higher levels of autonomic nervous system as well, so we've seen that. So these are the stress response systems that we begin to study and know that are abnormal in frail compared to non-frail people. We also know that they're more glucose intolerant, so again, these energy and endocrine system domains, I think there's more evidence than I put on this circle as well, but these are probably the two biggest physiologic domains that we know about where they're different in frail compared to non-frail, and they're probably driving a lot of these things we see in the clinic. And then ultimately down there, those same molecular changes that I talked about, and especially I think mitochondrial dysfunction is increasingly clear that that's probably driving changes in both of these areas. So again, back to the frailty phenotype, we're trying to find the biology here that's driving these signs and symptoms and the other medical changes that we see in people. So again, two major etiologic domains I talked about: chronic activation of stress systems, and especially chronic inflammation, and I'll get into a little bit more detail about that. And then altered energy metabolism, especially related to mitochondrial decline. So if I had to pick two areas that we've probably made the most progress in, still a ton of work to be done, it would be chronic inflammation and mitochondrial changes. So in the stress response systems, if you think about it, when an organism gets stressed, a lot of things happen, right? So you turn on all of these physiologic systems. Think about if somebody's getting surgery, they get injured with the incision, they get a lot of drugs that probably activate some of these systems, some that actually try to calm them down through anesthesia and pain medications, but these systems get very highly activated, And then when the stressor is gone, the systems get turned off. But in frail people, what we found is that these systems get turned on, and they don't ever get really turned off all the way like they should. They just sort of stay on. So low levels of inflammatory mediators are coming out. I'd say about 25 to 30% of what you would see in a very high response. We see just ongoing in frail people. Same with sympathetic nervous system, levels of cortisol, and activation of the renin-angiotensin system. And I'll get into some of the details of that in a minute. And again, this is a sort of a very broad overview. We have many more very specific studies that have kind of led to these conclusions that these are the systems that we think are important. So if you think about these systems, they interact, certainly. They can be activated individually, but often they pull the other systems together, and they tend to activate each other. So what we see then is this kind of change in all of these systems feeding on each other. So higher inflammation leads to higher HPA axis activity, higher sympathetic nervous system, and you kind of get a cycle of activation of these stress response systems in frailty. And we know the angiotensin system plays a role in this. We're not quite sure. There's some interaction there. We spent a lot of time working on that and thinking about how that changes with aging. But the end result then is that a lot of mediators that come out of these systems, things like CRP or IL-6 or cortisol or epinephrine, norepinephrine, are basically there all the time in higher levels than they should be. And those do have a downstream impact on lots of different things, cognition, depression, organ and tissue specific changes, more fibrotic tissue changes, more cell death probably, activation of disease states, making chronic diseases worsening, and then the development of disability, usually through muscle-related pathways. So we do think that these are not innocent bystanders. They're absolutely necessary when there's a real stressor there, and they help heal the body quickly and help move on to the next phase. But if they stay on all the time, then you begin to see all these other things happening. So chronic inflammation, basically we define that as a low-grade activation of the innate immune system. So it comes from some cells, but it also comes from a number of tissues like fat tissue, some fibroblasts that have had senescent changes. We know that it's associated with a host of adverse health outcomes: frailty, mortality, disability, progression of disease states. And this is a sort of a schema of how you get to these inflammatory mediators. Again, just an overview. So free radical biology, you've heard probably some about that. As mitochondria change, you get increasing levels of free radicals. It turns out that things like hydrogen peroxide activates NF-kappa B, which is basically an inflammatory pathway activator, and leads to these inflammatory mediators. So if you have lots of free radicals floating around, these pathways get activated, and you have more inflammatory mediators. TNF receptors and TNF alpha, this is a very early inflammatory pathway that turns on these pathways. So disease states, cancers, it can activate it. So chronic diseases will get you more inflammation as well. Toll-like receptors, any chronic inflammatory infectious disease processes, even chronic CMV that older people often have been exposed to, can lead to low-level shedding of these kinds of receptors, which also then activate it. And IL-1 is usually a disease marker in early activation of these pathways, and you end up getting more inflammation as well. So you can see there's lots of ways to get there. We don't know exactly how it happens in individuals, and I think over time we'll learn more about how you get from these signal pathways to these molecules that then we think do change the body in ways that make them more vulnerable. So I'll just talk about a couple of the cytokines, because I think in the coming years there may be more diagnostic usefulness to these. So IL-6 is an inflammatory It's a pleiotropic cytokine, and it's absolutely necessary to build skeletal muscle. So imagine after a big exercise bout, lots of IL-6 comes out, and it tends to activate satellite cells and all the things you need to build muscle. But if it sticks around for a long period of time, instead of a burst and then a fall off, you start seeing a negative impact on satellite and blood stem cells, so that low level of anemia that you see in older people sometimes is probably coming from this chronic IL-6 signaling, because it shuts the stem cells down in the bone marrow. And it also impacts the muscle satellite cells. It tends to change the immune system over time, and you get a proliferation of these more senescent immune system cells. So even though there is a reasonable number of immune system cells, they don't tend to work very well in a frail subset of older people. And again, it comes from this. We've seen in studies of flu vaccine that frail people don't respond very well at all to it. And it's probably because they have this kind of changed immune system cell profile. We know that it drives mitochondrial dysfunction as well, so more IL-6 over periods of time will change mitochondria, and it'll lead to more fibrotic tissue changes, and it triggers angiotensin signaling as well. So you kind of get this chronic activation of pathways that begin to damage tissue and put people at more risk of having adverse outcomes. The other molecule that's been of great interest in the last couple of years in the literature, and this is not only in frailty but also in many other chronic disease states, is TNF-alpha receptor 1. So TNF-alpha is an early inflammatory signaling molecule. It binds to this receptor, TNF-alpha receptor 1, and they're often in the serum. And once it's bound, it then goes on to do some activating of various systems. One is apoptosis, or cell death, and it does signal cell death for the cell to kind of go through these pathways, which then in turn accelerates cell loss and aging. So frail people are known to have sort of overall lower cell counts as they begin to kind of shrink down. There's some pretty good literature that supports that from many years ago. It may well be related to these chronic activation of these pathways. And this tends to further activate inflammatory pathway activation and disease, so it amplifies itself. So the more of this that you get, the more the systems get turned on. And we see this in cancer patients, people who are in late-term cancer. A lot of that sort of shrinking and wasting that you see in cancer patients is due to this pathway of signaling. And it also drives many other changes. It can also increase the risk for other kinds of cancer and supports metastatic development. So once these systems get activated, they tend to do lots of things that change a number of systems and make people at higher risk for bad outcomes. So we've used a mouse model to help capture some of this information. This is a mouse that has lost its IL-10, which is an anti-inflammatory cytokine, so it tends to get high levels of IL-6 relatively early in life. This is a normal mouse, and this is a chronically inflamed frail mouse, we would call it. They're the same age, but you see there's got the humped back already. It just doesn't look very well. It's lost some hair. And they tend to die faster. They die about 3 or 4 months earlier than these wild-type mice, which is pretty similar to what we might see in a sort of a frail trajectory versus a non-frail trajectory. So we've used these mice to come up with some I think, important basic discoveries. Again, it's lots easier to study tissues in mice than in a frail older person. You can imagine trying to get muscle biopsies, and it's sort of an area fraught with difficulty if you're doing human subject research. But just quickly, this is a paper we published in PNAS back in 2011 of mitochondrial angiotensin systems. So the drugs that we use commonly to treat blood pressure in older people, the ACE inhibitors and the losartan family of drugs, turns out probably have a big impact on systems well beyond the vasculature. So we found the receptors actually inside of mitochondria. These are mice mitochondria from kidneys. And when the mice are younger, let me just look up here. There's 2 types of receptors, basically type 1 receptors and type 2 receptors. And this is a young mouse, and you see the type 2 receptors are the ones that are anti-inflammatory. They tend to increase blood pressure. So you want more of these around to kind of have a more normal blood pressure phenotype. This is the type 1 receptor, and you see a few of them in the mitochondria. And as these mice aged, you see a lot fewer of these type 2 receptors in the mitochondria. So on this side, you can see lots of them here, the little black dots, and then much fewer. And then when the mice were treated with losartan for a period of time, you see a significant increase in the number of these type 2 receptors coming back. And you see that the type 1 receptors are increased with aging, and then with losartan treatment, they sort of drop in number again. So you get this better ratio, improved ratio with treatment of these drugs. So it's not just working on the vasculature, those drugs, they tend to be working at the level of the mitochondria, changing the energy flux. There are many other kind of studies associated with this that show that this really did have a functional difference on how mitochondria work. So in the autophagy, mitophagy world, there's this whole area of interest in looking how cells are recycled, or the interiors of cells are recycled, and we know that this happens through a cell program that basically surrounds little broken proteins and ends up getting acid hydrolase bound to that and breaking these up. So it's like a cell recycling pathway. And we know that it becomes dysregulated with aging. And we found in these mice, these are mitochondria in mice. You see these little beds of mitochondria here. We know that there are many more of these autophagy bodies. They tend to accumulate. They're not getting destroyed as they should and recycled, so they start accumulating, and you see a lot of damaged mitochondria in the tissues as well. So this is an important part of what we think of is happening in frailty. So frail people, we've done this in mice. We've also done some experiments in humans that suggest the same thing is true. So you see a normal mitochondria here. This is a depolarized mitochondria. There are lots more of these in the tissues of the frail mouse compared to the non-frail, and also now in humans we've seen that as well. Along with that, we also see a significant change in energy flux. So these are just ATP molecules in the change from an inactive inorganic phosphate to ATP. See IL-10 mice, these chronically inflamed mice, have far less ability to go through that flux, and in the end, when they're older, have less energy production in their muscles. Okay, in the last 10 minutes or so of the talk, I wanted to go through the translational efforts that we've done. And again, I think it's good to do this basic science research. It's really important. I think we found some areas that we can begin to highlight, but at the same time, I think it's very important to quickly get some of these things, some of these findings into medicine. So I'll talk about a couple things that we're doing at Hopkins to begin to work on that. So when we're thinking about translation, where do you focus? Should we go right to the molecular level? Should we go to the cellular level? Should we be thinking about these stress response systems? Should we try to change those? Should we do endocrine targeting, energy metabolism targeting? So it's been hard to know exactly where to focus. Over time, we've certainly identified changes and want to pick the right one. And because it's such a complex biology, we don't know which one is happening first. So we've kind of stumbled into a couple of things, and I think that's probably been our approach so far. Unfortunately, we've had some good luck with a couple systems that I'll talk to you about in the areas of clinical research that are happening there. So chronic inflammation, I've talked about that, angiotensin system alterations, vitamin D deficiency. I won't talk about that, but there certainly is lots of evidence out there that there's probably underdiagnosed vitamin D deficiency in older adults. The studies aren't exactly clear as to how much people should get, what the right vitamin D level is, and it may be that there are different cutoffs for different age groups and different ethnicities. We don't quite have the level of detail yet, but increasing evidence in that area. And then the area of metabolomic discovery, we've got some new evidence that we've been working on and related to chronic inflammation and the activation of some pathways there. So these are the four targeted areas that we've been thinking about. And these two, the first two are where we've spent most of our time, and I'll talk a little bit about the clinical studies we've done. So again, chronic inflammation, we use serum-based measures of inflammatory cytokines as surrogates, right? So you know these systems are activated. We don't know exactly why they're activated, what's doing it, but we know that the outcomes are these inflammatory cytokines. There's been hundreds, if not thousands, of studies right now published that show relationship between cytokines and frailty and 100 other adverse outcomes in older adults, and almost every kind of disease, chronic disease condition as well. So if people have more chronic inflammation, they tend to have worse outcomes over a period of 2 to 5 years. One study we did back now about 4 years ago was looking at a bunch of different inflammatory mediators. So we started with 25 inflammatory mediators in a big population study of about 6,000 people. And we ended up winnowing it down to 5 that were the best predictors of mortality. And this says log in front of it, but these are the molecules: CRP, IL-6, TNF-alpha receptor 1, IL-18, and IL-1 receptor antagonists. So these were the 5 top performers at predicting mortality. And basically over here, this is the hazard ratio of for mortality over a period of, I can't remember if this was 5 years, I think it was 5 years. For frail, for a big population study. And basically the outcomes here, you see that as expected, if they were older, they were more likely to die, right? So you see that higher hazard ratio there. And these other ones were significantly predictive of mortality as well. But you see IL-6 and TNF-alpha receptor 1 performed the best in the population. And then if we combine them into we used a couple different statistical models, and the combination of these two predicted mortality almost as well as age. So we think that this combination, one or both, performs very well in finding people who are at high risk of mortality at least, and we've done it in several other populations now and are beginning to see the same related to disability and other adverse outcomes. So the NIH has sponsored several studies recently looking at ways to better diagnose chronic inflammation, to look at some of the variability in these cytokines and begin to identify ones that really will have some predictive validity and could be used in a setting of chronic inflammation. And also, importantly, they've also sponsored many studies now to try to tamp these signaling down. So we think that if you can quiet the inflammatory signaling, at least that's the hypothesis, the risk of all those other disease states and disability will decrease. So there's several clinical trials ongoing now in older populations for using mild anti-inflammatory agents to see if that improves outcomes. I talked about this study already. So we use this information to leverage it into treatments for both muscle and skin. This is a study we did, again, it's been a few years now, but this was a mouse study where the muscle was injured with a snake venom, so cardiotoxin venom was injected into the muscle. And some of the mice were treated with placebo, and some of the mice were treated with losartan. And some of the mice were not injected at all. So after 19 days, so you see a scar pattern here emerging in the placebo-treated mouse. So they were injected with a injury agent, and you see white blood cells infiltrating there and some fibrotic tissue changes. And you don't see a nice normal muscle pattern. Maybe at the edge of that you see some beginning to come back in. But in the losartan-treated group, the muscle healed very quickly and went really pretty much back towards a control within about 19 days. So we were surprised at how quickly that impacted that. And again, probably because of the improvement in mitochondrial function and the dropping of the TNF-beta signaling, so we see lots less scar formation. We also showed that it decreased disuse atrophy. We know that older people, when they are placed in bed or injured, they lose muscle mass very rapidly, and we showed that losartan treatment in the mouse model at least preserved muscle mass. So these have led to some other clinical studies that are ongoing in the United States about the use of these agents to preserve muscle mass as people get older. Again, we'll see how it works. There's certainly a subset that might benefit from this and probably a subset that will not. I think the most important finding that we've had in the last few years is related to wound treatment. So we use the same information to begin to look at chronic wounds in older adults. So we know that the angiotensin system is dysregulated in wound bases. That's been shown in diabetic patients. That sort of shift of AT1 to AT2 receptors has taken place. So these are wounds in an old diabetic pig. And this is treatment, no treatment, a placebo group. And you see that sort of slough tissue in the middle of the wound and a little bit of granulation tissue coming in around the edge. It took, I believe this was 40 days to get to this point. So this is what you would see in a wound that just is not healing. And in a reformulated sartan treatment that we've been working on, you see that the granulation tissue, this stuff, filled in completely that whole wound. This is a matching wound, actually. So imagine the pig had a wound on one side and the matching treatment wound on the other side. So this is exactly the same size of wound. And you see the epithelium beginning to grow back in already. So there's none of that happening here, maybe a tiny bit at this margin, but you see a rapid recovery. And these were all completely healed at 60 days. So we think that this biology that we kind of stumbled into in the AT1, AT2 receptor change can be leveraged to improve treatments in frailty and in older adults in general. This just shows some other information about what the collagen looks like underneath. So this is the treated group. You see the epithelium is coming back in on top. You see a nice pattern of collagen, and here you see the untreated or the placebo-treated. You see kind of a gradual change in here, but not completely filled in. And I think this is probably the most important figure. You see the collagen in the treated wound, a very tight knit, sort of regular pattern emerging, whereas in the untreated group you see this large sort of disorganized collagen fibers coming back into the wound. So. And that had some value in the toughness of the skin that was regenerated. So you see, this is just a study that takes the skin on the margin of the wound after the study's done, and it basically pulls until it snaps, and basically showed that the treated skin was tougher, took more force to pull apart. You can see that here than the control group. So not only did the wound heal faster, the quality of the healing was much improved with this particular agent. So I use that as an example to show that the biology that we're working on related to frailty actually can relatively quickly get moved towards clinical practice, and we hope in the coming years we'll have some new wound care solutions for frail and older people in general, diabetics in general, but also some diagnostics related to chronic inflammation and mitochondrial changes that we think impact these bad adverse health outcomes in frailty. A newer study that we published recently in journal Circulation, we also found some autoantibodies to the system that were originally discovered in the toxemia of pregnancy, so women that have a lot of problems with hypertension and edema in pregnancy is probably related to this autoantibody that gets generated, binds to these receptors, and causes hypertension. We found in the frail subset that these are also elevated and probably are playing a role through the activation of these systems chronically in driving some of the adverse health outcomes. So continue to work in that space, and hopefully we'll have some more information about that in the coming years. Again, all of these things are in the early clinical translation phase. We've at least got some studies in humans. Most of them have emerged from animal studies now and are beginning to be studied in humans, and hopefully we'll be able to get them out into practice in the coming years. So, summary, physical frailty construct can identify vulnerable older adults for biologic studies. We think that there are very important biological domains that include stress response pathways and mitochondrial decline. Those are probably the two areas in frailty that we think are the most important. These and other etiologies lead to this platform of vulnerability in older adults, which lead to all of these other adverse health outcomes we see: advancement of disability, mild cognitive impairment, falls, and early mortality. And then we think that the discovery holds great promise for new diagnostic and treatment options for older adults, things that we haven't really thought about. They're not really disease specific. They're not for hearts. They're not for cancer. They're for sort of overall general metabolic and stress response system improvement. One of the issues we've had with that in the US at least is that the FDA, the agency that monitors and regulates drug production in the US, they like it to be pinned to specific disease states. So with the condition of frailty, we're not quite to the point where it's a widely accepted diagnosis that you can target. So we're hoping to move in that direction in the coming years. So sarcopenia has had the same fate in most places around the world. It's not been moved into clinical practice in any meaningful way yet, but hopefully down the road we'll begin to see that. Got a great group. This certainly isn't all my work. I want to highlight Peter Abadir here has done a lot of the work. We have a really sort of a broad-based interdisciplinary team that works on this science. Sean Lang is an immunologist and a geriatrician. So we're probably one of the few groups in the U.S. at least that has trained geriatricians who do basic science work and clinical translational work. So again, Sean, Peter, myself. Tae Chung is a physical medicine doctor who has some really interesting metabolomic discoveries related to nerve dieback that we think are going to be very important. So the loss of the connection between nerve and muscle is certainly important in aging, and he's got some new findings that I think will be coming out soon and important. And Dr. Westbrook here is a new fellow that's joined our group, and he studies metabolomic and metabolism changes in aging, and I think we'll see some great work from him as well. And then just a great team of people that have worked together now for several years and kind of moving this ahead. So I have not done this alone. It's definitely a team sport. So, and then the funding that we've gotten over the years, and for all the problems of the U.S. government, the funding from the National Institutes of Health, I think, have been very, very generous in a way that have helped us to do this kind of work. And even the recent budget that came out has increased money for aging in the coming year. Most of it's going to cognition decline and Alzheimer's, but certainly some of these other geriatric-based programs are beginning to get more money too. And so we have this Older Americans Independent Center, which is a big umbrella grant that allows us a lot of free rein to study at least pilot projects in frailty. Then we can get more funding to make them into bigger programs. So again, that certainly is what's been paying for our work over the years. So thanks to them as well. So, and thank you for your attention. Greatly enjoyed being here. It's and again, it seems like there are more geriatricians in Spain than there are in the United States. You guys, I don't feel as lonely here.
Thank you, John, for this really nice and inspiring talk about frailty. I think that it has raised not only new insights in the field of frailty, but also some new or very new hypotheses that is very good for people who is doing research. Here now in the audience we have clinical geriatricians, but also we have basic researchers from labs to the clinics and to epidemiological cohorts. So we have 10 minutes for questions, comments, and suggestions. If somebody in the audience, please. Marco. But I think we have a microphone somewhere. Yes. There. And there. Okay. We have two.
Thank you so much for your great presentation. I have a question relative to, the most suitable...
Sorry, please introduce yourself.
Yes, sorry. My name is Marco Enzitari. I'm a geriatrician working here in Barcelona and previously also funded by the Pepper Center of Pittsburgh, United States for a while, a couple of years. The question is relative to the intervention you showed. You are trying different molecules which would work on the pathways that you showed. I was interested in the comparison of the effect of these molecules with exercise, for example. So I know that there is a lot of literature on exercise reducing inflammation and so on, but are you also conducting studies on exercise and also probably maybe looking at let's say, inflammatory or additive effect of exercise plus these sartanic molecules or other that you are tasting?
Yeah, so we have not done any of the exercise studies. So those have been funded extensively over the last 20 years in the US, and that funding period seems to be coming to an end because I think it's been so proven that exercise impacts these systems in ways that medicines often cannot. So our first recommendation is still always exercise, and in many cases it will help re-regulate these systems and decrease the sort of variability that you see in both inflammation and HPA axis signaling. So there was the life study has shown some of that with inflammation, and I think even at the oldest age groups it makes a difference. So I would first not advocate for the development of a new pill to block inflammation. It would also be in addition to the exercise modalities. So right now, what the NIH is sponsoring are very sort of small-scale clinical trials just of the inflammatory mediators to see if you can get a signal that's not damaging. So that's the first stage. I think the next stage would be to try to combine the two in a bigger clinical trial. But our group is not doing that, but there are several groups around the country that are beginning to do that now. So,
thanks. Dr. Diez?
Adolfo Diez Perez from Barcelona and Cyberfest. Thank you very much for the fascinating talk. My question is, one of the most powerful treatments we have today for osteoporosis is a monoclonal antibody against the receptor activator of NF-kappa B. And I wonder if, and it's quite powerful in treating osteoporosis, I wonder if there is any data of effects of this or other anti-RANKL antibodies in other mechanisms related to aging or frailty.
Yeah, so people have tried to look at that, but usually a lot of this literature comes from big population studies and that get followed for years, and maybe a subset of, for the losartan information, for example, there may be 1,000 people on one of those drugs, and you can begin to get information on that. But for these rarer drugs that aren't commonly put into clinical practice yet, there's not a lot of epidemiologic information to see what happens to people over years. And I think there's a fear, at least in the States, of sponsoring studies like that because there's so many complications from the more powerful blocking agents, from things that are used to treat rheumatoid arthritis, for example. So blocking TNF-alpha receptor 1 or blocking IL-6, you might treat a bad disease like rheumatoid arthritis, but you put people in a really high-risk category. So when you start giving those medications to people who are in their 70s and 80s, you often see marked adverse outcomes. And so I think at this point it hasn't advanced to that, but I would say over time we'll begin to see some evidence if that is impacting some of these aging pathways. And if there are agents that are particularly mild and don't have a lot of potential for sepsis or the development of cancer, then I think certainly we would begin to think about including those in some studies.
Thanks. Professor Viña.
José Viño, University of Valencia. I had two questions. One was on exercise precisely, so you've already answered. Thank you. The second one is, there are molecules that are being tested for longevity, and I don't know if they're useful for frailty, like metformin, rapamycin, etc. Rapamycin, in my opinion, will lead to sarcopenia, I don't know. But what is your opinion on these molecules regarding frailty rather than longevity?
Yeah, so I think it gets back to the previous question too. There's these categories of drugs that appear to have very broad impact on aging phenotypes. And I think metformin, because it's been so well studied, its toxicity profile is extremely low compared to some of these other drugs. I think that is something that is getting pushed, in the States at least, to try to prevent frailty and the emergence of these kind of late life changes and high risk profiles. But the issue there again is funding. Companies don't want to pay for it. The NIH doesn't especially want to pay for it because there's no specific diagnosis that it's tagged to. So frailty again is, although we as geriatricians know there's something different about frail people, it hasn't risen to the level of a clinical syndrome with very firm diagnostic profile that you can say, okay, this person's frail, we're going to put them on metformin, for example. So we haven't got there mostly for that reason in the U.S. I think that it's happening through foundation money, the metformin branch. The rapamycin, I think, is still a little bit too early. There's been a fair number of side effects with that, the development of diabetes. And again, this subset of frail people are really very at high risk of having complications from drugs. So I think at this point, it would be better in a 60-year-old population to see and keep them on it for 5 or 10 years to see the trajectory rather than putting people who are already frail on it because of the complications that we see. So,
thank you.
Thank you. Any other question? Yes. Dr. Enriquez?
Hi, I'm Jose Antonio Enriquez from Madrid, Semeg. I'm not MD, I'm just a basic researcher. And yes, from your talk, I would like your impression, it's more a philosophical question than others, is that it is frailty as a feature that is not avoided for everybody that age, or is just an additional biological component that distinguishes clearly from the normal aging?
I think I've come to think of it as an accelerated type of aging. I mean, all of these biologic processes are happening, and we're not going to change the trajectory of that. I think the goal, I often get in arguments with people saying, subspecialists saying, what are you doing keeping these old people alive forever? What are you trying to get at? And I look to them, I'm like, why are you treating their heart disease? You're keeping them alive to live to their 80s or 90s. So I think we're all in it for the same thing, to keep people healthy, to keep them active and vital into late in life. But I think underlying all of this is a slowly progressive biologic change that we're not going to really change the trajectory of. We can maybe push it back into the late, and maybe into the 90s at this point. So I've come to think of frailty as an accelerated aging phenotype, and it could be driven by any of those domains around that loop.
So and then in your studies, there is any idea of a genetic promoters or genetic retarders, or there is no information yet?
So the U.S. tends to fund things in these big waves. So 10, 15 years ago, there were many genetic studies. The GWAS studies were funded in great numbers. And some people have looked at it, and we really haven't found any major signal. Some maybe nuclear receptor signal activators that may show a little bit of association, but really nothing major. And I think, again, because of this phenotype is so difficult, it's not like a typical genetic phenotype that you see in like cystic fibrosis, for example. It's something that emerges late in life. It's so variable, it's hard to know. It's a little bit more like type 2 diabetes. Millions and millions and probably billions of dollars were poured into genetic studies of type 2 diabetes with a couple little signals here and there that may have made some difference, but I think frailty is even in a league beyond that.
Gracias. ¿Alguien que quiera hacer una pregunta en castellano pero le da corte porque no la sabe decir en inglés? Si queréis, la decís en alto, yo intento traducirla. ¿Alguien se anima? Bueno, pues entonces me animo yo, la hago en inglés. Because I have the privilege as a chairman to make you the last question. And in some way I'm coming back to the issue about metformin. Sometimes I have the feeling that we are studying different mechanisms that are part of a common final pathway of response to things that is happening before. Of course, we are in a cycle, and when you go into the cycle, you have oxidative stress, you have pro-inflammation, you have increase in angiotensin responses, but who is underlying, who is triggering this? And in particular, what is the role of insulin resistance in the triggering all of these mechanisms that are associated, among many other issues, to insulin resistance? What is the role for insulin resistance in your opinion?
So I think it certainly plays an important role. It's a strong association with people who are frail, even if they're skinny. I think it ultimately has to do with the mitochondrial biology and the ability of the mitochondria to generate energy or to utilize energy substrates. So I think there's a lot of work to be done there. If we figure out a bit more about the function of mitochondria and the ultimate changes that are happening there, I think that will begin to unravel those or answer some of those questions. I think metformin probably plays an important role in mitochondrial biology that we don't yet fully understand. So if I were to bet, I would put my money on mitochondrial changes as underlying causes of this. And again, it is a common final pathway that ultimately we probably can't do much about. We can push things back, but that's what everybody does in medicine, and keep people alive and healthy as long as possible. So.
Okay, thank you. This is a good news because when he has told us that he should put the money in it's very rewarding because he's a very wealthy man. No, that's it.
But so, no, my first advice though is still exercise. You can't. Back to the first question. There's no pill that's going to solve anything. You have to exercise and eat well. So those are key things. So
thank you so much, Jeremy. It has been a very, very, very inspiring talk. We are very proud of having you as an honorary member of our society, and hopefully we will have the opportunity to meet you in many other times. So thank you very much.
Thank you. Thanks for having me.
And now we are going to the next session. Coffee break.